Tension dysphonia is a condition of extra vocal work and strain. Most of the time, it is due to extra effort that one puts onto voice to try to work around another vocal problem. More rarely, it can occur all by itself. It involves putting extra effort into vocal tasks that perhaps is not necessary or required to make sound. This can actually lead to worsening of voice and other throat symptoms, leading to muscle tension dysphonia. Muscle tension dysphonia is considered a functional disorder rather than neurological. It occurs when the speaker exerts too much pressure or effort on laryngeal muscle, causing the voice to sound tight or strained. This tension prevents the voice from working efficiently. It's sometimes referred as hyperfunctioning voice disorder. Muscle tension dysphonia is two types. Primary, the muscle in neck are tense when talking, but there is no abnormality in the larynx. It means pathologically and structurally larynx is normal. While in secondary muscle tension dysphonia, in this type there is abnormality in the voice box that cause other muscles to compensate help produce sounds like vocal nodule and polyp lead to the compensatory hyperfunctioning of the muscle of the larynx. This causes overuse of these other muscles because they are not normally tasked with this type of the work. This MTD is most prevalent among people between 40 to 50 years of age and more common in female than the male. This can present with wide variety of symptoms like roughness, hoarseness, raspy, weaky, breathy voice with whisper, strain, squeeze and tight voice. So these are the common symptoms of this MTD. The condition hard to diagnose and often misdiagnosed. It is diagnosis of exclusion. You have to rule out the spasmodic dysphonia and other structural and pathological condition by rigid telescopy or 90-degree endoscopy. There are two hypotheses of muscle tension dysphonia. First is chronic imbalance of the muscle pull. For example, cricothyroid muscle can lead to irreversible joint damage and ligament stretching, giving a flaccid board appearance to the vocal fold. Second is viral neuropathy has developed, causing the hypertrophy of the thyroid node muscle and consequent poor glottal contact and secondary compensatory hyperfunction. The evidence to support this come from electromyographic studies. So these two hypotheses lead to muscle tension dysphonia. So MTD is therefore a group of conditions characterized by imbalance of synergistic and antagonistic muscle affecting the vocal fold position and tensioning relative to one another. Also the position of laryngeal vocal tract. Usually, this is hyperfunctional state of the laryngeal muscle rather than hypofunctional state. Hypofunctional state are end stage of hyperfunctional laryngeal activity. True hypofunctional cases do exist in neurological conditions such as myasthenia gravis, Parkinson's disease, and motor neuron disease, but they are relatively uncommon. So, this MTD is hyperfunctioning state of muscle activity rather than hypofunctioning activity of the muscle. Some conditions like myasthenia gravis, Parkinson's disease, and motor neuron disease may have hypofunctioning state of the laryngeal muscle that may lead to muscle tension dysphonia. There are multiple primary etiologies of MTD, including stress, anxiety, depression, conversion disorders, postural and breathing problems, poor vocal hygiene, talking in poor acoustic environments or above background noise for prolonged period at work or socially, exposure to excessive environmental dust, smoke, and fumes. The degree of dysphonia is variable, ranging from intermittent problem related to particular voice task. Maybe other symptoms are pitch of the voice may be too high, too low, reduce in range, a sensation of tightness, constriction, or lump in the throat, effortful voice production, discomfort on speaking or singing, and vocal fatigue. These are the symptoms of this MTD. On laryngoscopy, there are six laryngeal patterns can be seen. First is type 1, laryngeal isometric disorder. Type 2A, lateral glottal contraction. Type 2B is lateral supraglottic contraction. Type 3 is anteroposterior glottal contraction. Type 4 is convergent aphonia or dysphonia. Type 5 is psychogenic dysphonia with board folds. Type 6 is adolescent transitional dysphonia. So these are the six patterns can be seen most commonly on laryngoscopy of this MTP patients. Treatment mainly address the underlying causes, vocal hygiene, dietary lifestyle advice, vocal therapy for specific muscle group, laryngeal manipulation, behavioral therapy, and medical treatment to underlying causes like gastroesophageal reflux disease.